Hello, so today we're going to go through my search pattern whenever I look at a chest CT. So the first thing I do when I do this is to have a quick scroll through to see if there's any big glaring abnormality. And if there is, I'll go into a bit more detail and have a closer look at this and any associated findings. Now once I've done that, I will then always fall back on doing my same review system, and by doing so, it will just reduce the chance that I'll make any errors or miss things. So the first thing that I'm going to do is look at the airway. We're going to start with the trachea, which I can see just over here as this black circle in the middle, and we're going to follow it down, and that should branch off into the right and left main bronchus. So I can see the right side over here and the left side over here. The right side, you've got 3 lobes rather than the left where you've got 2. So on the right, I can see this whale shape coming off here. This is your right upper lobe bronchus, and that's going to split into 3 with 3 segments. Firstly, you've got your anterior segment coming off here. We've got the posterior segment coming behind over here. And then if we scroll up towards the apex of the lung, we should see our apical segment coming off over here as well. If we follow that down, once the right upper lobe bronchus has come off, you've then got what we call your bronchus intermedius, and that's going to split into 2. It's going to go anteriorly into your middle lobe, so quite easy to remember, that just has 2 segments. You've got your medial segment bronchus over here and your lateral segment over here. Remember, it's your medial segment that abuts your right heart border, so if you get your loss of silhouette sign on your chest x-ray, it's because you've got something within the medial segment of your middle lobe. Now we're going to follow that back, and we're going to see it then split off, middle lobe going anteriorly and then lower lobe coming posteriorly just over here. Now in terms of segments of the lower lobe, I like to think about it as looking like a house with 2 floors. On the top floor you've got 1 room, and that over here is your apical segment bronchus, which is over here. So that's the top floor of the house, and on the bottom floor you've got 4 rooms, and the mnemonic I like to use is MALP, and here you've got your medial, anterior, lateral and posterior segmental bronchi. So that's the right side. So then we'll have a look at the left side as well. So this time we'll come off and we'll go into the left main bronchus. Now the important thing to remember is that there's 3 differences I would like to think of the left side of bronchial anatomy compared to the right. Number 1, instead of apical and posterior segments, you've now got an apico-posterior segment. So those 2 segments have formed 1 on that side. Secondly, instead of a middle lobe, you've got the lingula, which is part of the left upper lobe, and those airways come off the left upper lobe bronchus. The third thing, instead of a MALP, you've now got ALP. So you've got an anterior, lateral and posterior segment. So let's go and have a look at the left upper lobe airway. So you've got left upper lobe bronchus coming off here, and then that's going to split off into your anterior and your apico-posterior segmental airways, and we can follow those up right up to the apex. Then remember, your lingular airways are going to come off your left upper lobe bronchus. So straight away, the lingular has 2 segments, much like the middle lobe, but instead of being side to side, they sit one on top of the other. So you've got your superior and inferior lingular segments rather than your medial and your lateral segments. So this is your superior segmental bronchus, and if we follow that down, we can see your inferior segmental bronchus there. Again, left lower lobe, a bit like a house. Apical segmental bronchus is the top floor, and then on the bottom, we've got 3 branches. We've got the anterior medial, we've got the lateral and the posterior segments. Now, what are we actually looking for when we look at these airways? Well, we're looking for 3 things. Number 1, is there any dilatation of the airway? So how can we tell that? Well, have a look at the corresponding pulmonary artery that sits next to the airway. This shouldn't be any smaller than the airway. So this is normal here. The pulmonary artery is at least the same size, if not bigger, than the corresponding airway. If the airway becomes bigger than the pulmonary artery, then we can say that there's bronchiectasis here, which there isn't in this case. The second thing I'm looking for is to look at the wall of the airway. So look to check that the wall of the airway is paper thin. If that becomes thickened, there could be some inflammation within there. Thirdly, is it all black inside the airway? is there anything filling it? So commonly mucus is the thing we see most often, but sometimes you can have tumour within airways as well. Carcinoid is a tumour that likes to grow within airways, what we call endobronchial lesion. So that is all of the airways. The next thing I do is then look at the lung parenchyma, and I like to do that by zooming all the way out and having a perspective that I can see both lungs side by side. And I'm looking to see, is there any abnormality such as emphysema? Are there any dark areas within the lung? Is there an interstitial abnormality? So can I see reticulation in the subpleural regions? Can I see traction bronchiectasis, for example? And I can't see any of that here. The lung parenchyma all looks pretty normal to me. When I go down to the bases, I have a look to see the position of the oblique fissures. So in a normal case, the oblique fissures you'll see is these lines over here. They should sit quite anteriorly at the lung base, and in this case I think we're just about okay. You might have lost a little bit of volume on this right side as the fissures come a little bit posterior, but this isn't too bad. I'm not going to make too much of that. The next thing I'm going to do is look for lung nodules. Now this can be very tricky, which is why most people use something called a MIP projection, so a maximum intensity projection. Essentially what we're doing here is, if you think of a CT scan as being made up of lots of 2D pixels, in a 3D world those are called voxels. Each of those voxels are showing us the mean density on a normal standard CT scan. However, if we change it to a MIP projection, we're then showing the maximum density within that voxel. That can really highlight lung nodules, so it's something that can be very helpful, and this is what we've got here. So the way I like to do this is by looking at the lung in different zones. So firstly, keeping my eyes drawn on the anterior part of the lung and screening to see all of the opacities I can see are related to branching vessels, and I think that's the case here. I will then have a look at the middle part of the lung and then also the posterior part of the lung, and I'll do that on both sides, looking for any lung nodules that I can see. If I do see any nodules, I will then see if I can see them on any previous scans, as it is fairly nuanced in terms of follow-up and workup of nodules, probably out of the domain of this talk here. But the bottom line is, if you have a solid nodule, the rules for ground glass nodules are a bit different, that is stable for a period of 2 years or longer, then we can pretty much say it's most likely to be a benign nodule. So that's lung nodules in a nutshell. So we've looked at the lungs, now we're going to look at the soft tissues and the mediastinum. Now this is a post-contrast CT, but my review areas would still be the same if this was a non-contrast CT, as I think it's a good habit to get into to review all of the mediastinal structures one by one in turn. So we're going to follow the contrast all the way through, and that will just ensure that I'm looking at all of the mediastinal structures in turn. So here we've got the contrast coming in through the right arm, and that's going to come into your right axillary vein, which will then become your right subclavian vein at the lateral border of the first rib. That will then split off into two, and you've got your right internal jugular vein, which comes up, and then your right brachiocephalic vein, which comes down. Now we've got this snake-like structure which is chasing that right brachiocephalic vein. I like to think of this like a snake trying to eat an apple. Those are your two brachiocephalic veins. So you've got left-sided over here and right-sided over here. Those join together and become your SVC, and then you'll see your azygos vein draining into the SVC, curving on the right side of the mediastinum there. If you follow the azygos vein, you'll see it track all the way down within the posterior mediastinum over here. If we come back up, we'll follow the SVC over here and we'll follow that down. Now that should meet your right atrium, which we can see just over here. Right atrium going into the right ventricle, which is the most anterior of all the heart chambers. So if you were to be stabbed within the chest, it's quite likely you get stabbed within your right ventricle. Right ventricle, follow that up, and then we should see our friend the pulmonary trunk. Now, when assessing the pulmonary trunk, the first thing I would say is look at its size. Compare it to the size of the ascending aorta. If your pulmonary trunk is bigger than your ascending aorta, then that may be a sign that the patient has pulmonary arterial hypertension. Then have a look for any filling defects within the pulmonary trunk. Now, a really important thing here is that it's important to have it windowed the right way. So what you don't want is for things to be too bright, as that can mask filling defects within the pulmonary arteries. What you need is to widen the window slightly so you can see a little bit of noise within the pulmonary artery itself. And then what I tend to do is to zoom right up and then follow the vessels each side. So you've got pulmonary trunk here, you've got the right main pulmonary artery over here, and then I'm going to follow it through and look on the right side and follow all of the upper lobe pulmonary arteries up. And remember that those come back on yourself this way as well. So follow all of the vessels each side. And I wouldn't be afraid to do this more than once, especially if you're doing a dedicated CTPA scan. I will then have a look at the middle lobe and also the lower lobe, and I'll follow all of those pulmonary arteries in turn on the right and then the left. So that blood then becomes oxygenated and it comes back into the heart via the pulmonary veins which sit over here. So I like to think of the left atrium as a spider with many flapping legs, and look to see if you've got at least 2 pulmonary veins draining in on each side. If you don't, those veins could be draining into the systemic system in something called partial anomalous pulmonary venous return. Now remember, the left atrium is the most posterior of all the heart chambers, opposite to the right ventricle, which is the most anterior of all the heart chambers. Left atrium then drains into the left ventricle, which you can recognise by its thick wall. So here you're looking for any thinning of the left ventricular wall, you're looking for any filling defects, but don't confuse the papillary muscles, which look quite prominent for filling defects within the left ventricle. Also have a look at the left atrial appendage, which I can just see as this little pocket over here. Filling defects within that may get missed, and those can be a risk factor for stroke. So really important that we try and pick those up. It can be quite tricky sometimes to tell the difference between that and contrast mixing, and if there is any doubt, then we can do a delayed phase CT scan to try and tell the difference, or if there is further doubt, then the patient may need a transesophageal echocardiogram. So left ventricle, we're going to follow through to the aorta over here, and then we're going to follow the aorta up. We're going to have a quick look at the coronary arteries. I can see the left main stem coming off here. And we're going to follow the aorta all the way up to the arch. And then further up, I can see the 3 branches of the arch of the aorta. So the mnemonic I like to use for this is big cheesy smile. B for brachiocephalic trunk. C is the left common carotid artery. And S is the left subclavian artery. And if we follow this up, I find this is a good time to look at the fat in this region here, looking for mediastinal lymph nodes within the superior mediastinum, and then looking for any supraclavicular or lower cervical nodes up here. And this is something that can get often missed on a chest CT. And it's an important review area in lung cancer patients, as finding nodes within this region here can upstage the patient from N2 to N3 nodal disease. And so it's a really important review area. Also, if you see nodes in this region in the context of cancer, it means that potentially there's a site that may be more easy to biopsy than something that's well within the chest. So I like to then review the rest of the mediastinum. So then I'm going to scroll back down and I'm going to look in and around the trachea. So we're going to look in the paratracheal region over here. That looks okay. And then I'm going to look at my hilar regions as well and look for any lymph nodes. I can see some small lymph nodes over here. These look okay. If you're unsure, you can measure them. Anything that measures less than 10 millimeters in their short axis is probably okay. If there is any doubt, you can always have a look to see if there are any previous scans, and those that have been stable for some time are less likely to be concerning. Now, we haven't finished looking at the aorta, so then I'm going to have a look at the arch of the aorta, and I'm going to follow the descending aorta down over here. Now, as I look at the descending aorta, I'm also going to keep an eye within the posterior mediastinum. So I can see the esophagus over here and the azygos vein over here. So within the esophagus, I'm looking to see for any obvious mural thickening that might reflect an incidental tumour. I'm looking for any fluid within the esophagus and also looking to see if there's any esophageal dilatation. At this time, I'm also looking for any lymph nodes within this posterior mediastinal fat or any masses that may live here as well. This all looks okay. I can see some tiny little nodes over here, but those are okay. That's not worrying. We're reaching the diaphragmatic hiatus here. And still I'm going to continue down and I'm going to look in this region here, which is the retrocrural region, to make sure there's no lymph nodes hiding within here. Again, somewhere where nodes are commonly missed. So I like to think of reviewing this stage of the CT as like a haircut with front, back and side. So we've done the back, now we're going to do the front. I'm going to go all the way back to the top, and then I'm going to look for these vessels over here. So I can see these two small vessels on the left and two small vessels on the right. These are your internal thoracic vessels, also known as the internal mammary vessels. And you've got your artery, which is more lateral, and the vein, which is more medial. If you follow this up, you'll see that the artery is arising from the subclavian artery over here. So this is your left subclavian artery. This is your left internal thoracic artery, which is arising from it. And I'm going to follow that down on each side. And what am I looking for? Firstly, to see if it's there. So if the patient's had a previous coronary bypass graft, they may have taken that lemur away from its natural position and plugged it into one of the coronary arteries. So it's a good sign that the patient's had previous bypass grafts. Also, it's a really important review area in terms of lymph node enlargement, particularly in breast cancer patients. So I'm always sure to have a look at that and track those down on both sides. Then when I get towards the bottom of the chest, I then use this as an opportunity to look at the paracardiac fat and look for any lymph nodes in this region. And I can't see any here. I'm going to follow that all the way through and also have a look at the fat in this region here and also within the front of the abdomen, and everything looks okay there. So the front looks okay. I'm going to scroll all the way up and use it as another opportunity just to make sure there weren't any supraclavicular nodes, which they weren't. So we've done front, we've done back, then we're going to do sides. So we're going to look at the right side first. And here I can see the axilla. So I can see some small lymph nodes in this region here. That's okay. This looks all right. Why do I say that? Well, this lymph node retains its fatty hilum. There's only a small number of them. And also in terms of its short axis, it's likely it measures less than 10 millimeters. When would I worry about these? Well, if it started to be a round morphology where it loses its fatty hilum, if there's an increased number, or the size is more than 10 millimeters, is when I'd start to be concerned about axillary lymph nodes. Once I've looked in the axillary regions, I'm also then going to look behind the pectoral muscles and look for any prepectoral nodes, which again you may see in cases such as breast cancer. And then I'm going to look at the chest wall itself, and if it's a female patient, look at the breast tissue, but also do that in a male as well, as male breast cancer is also a thing. And I'll do that on the right side, and I'll do that on the left side as well. I'm then going to make the scan very small, and the reason I'm doing that is looking for symmetry on both sides, because I'm looking now at all of the muscles and soft tissues. I'm going to go right to the top, remembering that things get missed right at the top or right at the bottom of scans. So I'm going to look at the soft tissues here. All looks pretty symmetrical to me, and I'm going to scroll all the way down slowly, looking to see if there's any soft tissue lesion that hasn't caught my eye already. Once I've done that, that's most of the chest done. I'm then going to review the abdomen. Now, really important to realise that a lot of things I've seen missed on chest CT is actually stuff within the abdomen, because once people review the chest, they think the job's probably almost done and then don't look at the abdomen in detail, in as much detail as they looked at the chest at. So the first thing I'm going to do is look at the liver, and to do so I'm just going to harshen the window a little bit, as that can highlight liver lesions. So we're going to scroll through the liver and we're going to look for any liver lesions that we can see. And if we scroll all the way back up, there is something that catches my eye just over here. So it's very tiny. I don't think this is concerning. How can I be sure? Well, I'm going to measure the density of this lesion. And if we check the density of this, we can see it's got a Hounsfield unit of 6, which is between 0 and 20. And so this is likely to be fluid density and probably a small, simple cyst. So I don't think this is worrying. I think we can dismiss that. So once I've scrolled through the liver, I'm going to review the rest of the abdomen as if I was reviewing an abdominal CT. So my normal technique is to then find the main portal vein, which is over here. It isn't highlighted very well because this isn't really the right phase to assess the portal vein, but I'm just going to follow it through to the splenic vein, which is over here, and follow that all the way to the spleen. And then that just reminds me, have a look at the spleen up and down. Once I've done that, I then look beside the spleen and see this thing here, which is the tail of the pancreas. I'm going to follow that all the way through to the head of the pancreas over here. I'm not seeing the unternate process because we haven't caught all of it on this scan. And then I'm going to have a look at the biliary tree. So I can just see the CBD over here, which then reaches the head of the pancreas. I'm going to follow that back up into the liver. That doesn't look dilated. And I can see the gallbladder over here looking fairly collapsed, and I'm not too concerned about the gallbladder. Then what am I going to do? I'm going to go all the way back up and look at the distal esophagus over here, and I'm going to follow that through into the stomach, and I'm looking to see if there's any obvious masses, if the stomach is dilated, and I'm following that through to the proximal duodenum. Now I can't follow the scan any further as this is the lowermost slice that we've got. But then I'm just going to cast an eye on all of the other bowel loops I can see. I can see the splenic flexure over here, and I can see other bowel loops over here. I can see some jejunal loops over here. These aren't dilated. These all look okay. Then we haven't looked at the adrenals and kidneys, so that's the next step. So I can see the adrenal gland on the left over here. I can see the adrenal gland on the right over here. And these should be as thin as this. They shouldn't really be lumpy at all, and those both look okay to me. I'm then going to scroll down and have a look at the kidneys, as much of it as I can see, and these look unremarkable as well. I'm then going to zoom out a little bit, and I'm going to try and just cast my eye on all of the fat spaces I can see within the abdomen. I'm looking for any lymph nodes or anything worrying that I can see. Now, you might have spotted this little nodule over here. This is something that's fairly common, something called a splenunculus, which is a little bit of accessory splenic tissue, which you'll see very commonly. But that's not worrying, and that's okay. Now, we're nearly done, and now we're going to look at the bones. So I'm going to do this very carefully on an axial review, and then I'm also going to look on the sagittal slices as well. So I'm going to start over here with the right humerus and the right scapula, and I'm going to follow those down. So that was the humerus and this is the scapula, and I'm going to follow that all the way down, and that looks okay. And I'll do the same on the left. Then I will have a look at the clavicle and follow that through, and that should meet your sternum over here, and the sternum is here. And I'm going to look for any lytic lesions or any fractures that I can see, and that all looks okay. I'm then going to review the ribs, and the way I'm going to do that is by screening in 3 zones on each side. It can be very confusing looking at the ribs, and they can be quite tricky to review. But in essence, what I'm going to do is have a look at an anterior zone, have a look laterally, and then a posterior zone. I'm just going to keep my eyes there, much like I did with the lung nodules, and I'm going to see if there's any issues in terms of a rib lesion or fractures, and I'm going to do that on both sides. In a trauma case, I might do that more than once, just to make sure that I've not missed any rib fractures, and I'm going to do that on both sides. Then I'm going to have a look at the vertebra and posterior elements. So here I can see a vertebral body, I can see a pedicle over here, which is part of the posterior elements, I can see the lamina over here, and the transverse process over here. I can also see the spinal canal over here. Now I'm going to scroll through the vertebra and the spine 3 times. The first time, I'm just keeping my eye on the vertebral body, and I'm looking to see if there's any fracture. I'm looking to see if there's any obvious lesion I can see. I'm going to also have a look on the sagittal view after this to see if there's any loss of height of the vertebrae. That can be difficult to appreciate on the axial review. Once I've done the vertebral body, I'm then going to have a look posteriorly at the posterior elements, and then just keep my eye on those to see is there anything that's affecting the posterior elements. So as well as the structures, as I mentioned before, you can also see on this slice we've got a spinous process here and the facet joints over here, and I can't see any major issues on this scan here. After I've done 2 reviews, I'm going to then do a 3rd review, and I'm then looking at the spinal canal and the soft tissues around the spine. And I'm looking to see, is there any soft tissue that's encroaching into the spinal canal? Is there fat in the paravertebral region that's not encroached by any soft tissue or lymph node enlargement? And I'm going to slowly scroll through. And this is very important. Although it's often that you won't see any abnormality, I have seen cases where abnormalities here have been missed. So I think this is a really important review area. And it's important to do this on a soft tissue window, as you may not appreciate the abnormality on a bone window. I've now got up the sagittal bone windows, and I'm going to scroll through on the sternum first, so scroll through either side, And then I'm going to have a look at the spine, and I'm going to do it in zones. I'm going to take a few vertebrae at a time and just scroll through one side, then the other, and then just go down the spine, scrolling one side, then the other, just to see, is there anything I've not missed? I'm making sure that the vertebrae look like they've got preserved heights. Over here, I can see a lesion that looks like a typical hemangioma in that it's got a striated appearance. These are fairly common, and I'm not worried about this at all. I will then use this opportunity to then have another look on the soft tissue windows, looking at the spinal canal and looking to see if there's any soft tissue around the spine I may not have seen originally. Once we've got it on the soft tissue windows, and then gives me another view of the abdomen and the mediastinal structures as well. I will then finish by having a quick look on the coronal view just to see if there's any major abnormality. Because I've been looking in such detail, is there something that's just slipped my eye line because it's such a big abnormality that I've not seen it? And I'll go back onto the lung windows just to give myself another perspective and to see if there's anything else that I've missed. And that's my usual review for looking at a chest CT. And if I've done all of that, I can be fairly certain that there's probably not a lot that I would have missed when looking at a chest CT. If you found this helpful, then please do check out the video on bronchial anatomy, which goes into a bit more detail of the anatomy of the airways, which I think is really helpful for whenever you assess a chest CT.